This is chapter 34, recording number 4, talking about respiratory conditions. Asthma, a condition in which the smaller air passages, bronchioles, become inflamed, swell, and produce excessive mucus, which leads to difficulty breathing. A true emergency if not promptly identified and treatment. According to the Center of Disease Control and Prevention, the CDC, 10% of children in the United States have asthma, and in 2007 alone, 185 children died of asthma. Common causes for an asthma attack include upper respiratory infection, exercise, exposure to cold air or smoke, and emotional stress. Signs and symptoms of asthma characterized by wheezing as a patient attempts to exhale through partially obstructed lower airway passages. In other cases, airways are completely blocked and no air movement is heard. Cyanosis and respiratory arrest may quickly develop. Tripod position allows for easier breathing. Treatment of pediatric patients with asthma. If possible, let the pediatric patient assume a position of comfort in a parent's lap. Administer supplemental oxygen via a route that's tolerated by the child. A bronchodilator via a metered dose inhaler with a spacer mask device may be administered based on local protocols. Often the parent or caregiver have attempted multiple dosages of albuterol. In this case, meet ALS providers en route for advanced care. If you must assist ventilations, use slow, gentle breaths. Resist the temptation to squeeze the reservoir bag hard and fast. A prolonged and unrelieved asthma attack may progress into status asthmaticus, which is a true emergency. Administer oxygen and provide rapid transport to the ED. If the patient becomes so exhausted that he or she stops struggling to breathe, the patient is not recovering and is likely going to stop breathing. Manage the airway aggressively, administer oxygen and transport promptly. ALS support should be considered. For pneumonia, according to the World Health Organization, pneumonia is the leading cause of death of over 2 million children worldwide annually. Pneumonia is a general term that refers to an infection in the lungs. Often a secondary infection occurs after pre-existing infection, such as a cold. It can also occur from chemical ingestion or a direct lung injury or a submersion incident. Children with diseases causing immunodeficiency are at risk for developing pneumonia. Incidence is greatest during fall and winter months. Presentation in the pediatric patient, usually rapid breathing or will breathe with grunting or wheezing sounds, nasal flaring, tachypnea, hypothermia or fever, unilateral diminished breath sounds or crackles over the infected lung segments. Treatment of pneumonia in the pediatric patient. Primary treatment will be supportive. Monitor the patient's airway and breathing status. Administer supplemental oxygen if required. If the child is wheezing, administer a bronchodilator if permitted in your EMS system. Diagnosis of pneumonia must be confirmed in the hospital. Croup, or laryngotracheal bronchitis, is an infection of the airway below the level of the vocal cords, usually caused by a virus. Typically seen in children between 6 months and 3 years old, it's easily passed between children. The disease starts with a cold, a cough, a low-grade fever, and develops over 2 days. The hallmark signs of croup are a stridor and a seal-like barking cough. Croup often responds well to administration of humidified oxygen. Bronchodilators are not indicated for croup and can make a child worse. Epiglottitis or supraglottitis is an infection of the soft tissue in the area above the vocal cords. Bacterial infection is the most common cause. Since the development of a vaccine against one organism that causes epiglottitis, the incidence of disease has dramatically decreased. In preschool and school-age children especially, the epiglottis can swell to 2 to 3 times its normal size. Children with this infection will look ill, report a very sore throat, and have a very high fever. They'll often be found in the tripod position and drooling significantly. Bronchiolitis, a specific viral illness of newborns and toddlers often caused by a respiratory syncytial virus, RSV. Causes inflammation of the bronchioles. RSV is highly contagious and spread through coughing or sneezing. The virus can survive on surfaces. The virus tends to spread rapidly through schools and child care centers. Most common in premature infants and results in copious secretions that may require suctioning. Occurs during the first 2 years of life and is most common in males. Most widespread in the winter and early spring. Bronchioles become inflamed, swell, and fill with mucus. Airways of infants and young children can become easily blocked. Look for signs of dehydration, shortness of breath, and fever. Treatment of bronchiolitis in the pediatric patient. Display a calm demeanor when approaching. Allow the patient to remain in a position of comfort. Treat airway and breathing problems as appropriate. Humidified oxygen can help if available. Consider ALS backup. Pertussis, also known as whooping cough, is a communicable disease caused by a bacterium that is spread through respiratory droplets. As a result of vaccination, this potentially deadly disease is less common in the United States. The typical signs and symptoms are similar to a common cold: coughing, sneezing, and runny nose. As the disease progresses, the coughing becomes more severe and is characterized by a distinctive whooping sound heard during inspiration. Infants infected with pertussis may develop pneumonia or respiratory failure. To treat pediatric patients, keep the airway patent or open, and transport. Pertussis is contagious, so follow standard precautions, including wearing a mask and eye protection. Airway adjuncts, devices that help maintain the airway or assist in providing artificial ventilation, including oropharyngeal and nasopharyngeal airways, bite blocks, and bag valve masks. Oropharyngeal airways, designed to keep the tongue from blocking the airway that makes suctioning easier, should be used for pediatric patients who are unconscious and in possible respiratory failure. Should not be used on conscious patients, especially those that have a gag reflex or who may have ingested a caustic or petroleum-based product. The nasopharyngeal airway, usually well tolerated and not as likely to cause vomiting, used for a responsive pediatric patient. Used in association with possible respiratory failure, rarely used in infants younger than 1 year. Should not be used in pediatric patients with nasal obstruction or head trauma. Potential problems. Oh, I went the wrong way. Potential problems. An airway with a small diameter may easily become obstructed by mucus, blood, vomitus, or the soft tissues of the pharynx. The airway is too long, it may stimulate the vagus nerve and slow the heart rate, or enter the esophagus, causing gastric distension, which may cause the spasm of the larynx, result in vomiting if inserted into a responsive patient. Nasopharyngeal airways should not be used when pediatric patients have facial trauma because the airway may tear soft tissues and cause bleeding into the airway. For oxygen delivery devices, in treating infants and children who require more than the usual 21% oxygen that's found in room air, you have several options. You can do the blow-by technique at 6 liters per minute, provides more than that 21% oxygen. Nasal cannula at 1 to 6 liters per minute provides 24 to 44% oxygen. Non-rebreathing mask at 10 to 15 liters provides up to 95% oxygen concentration. And then a BVM with oxygen reservoir at 10 to 15 liters provides nearly 100% oxygen concentration. Use of a non-rebreather mask, a nasal cannula, or a simple face mask is indicated only for pediatric patients who have adequate respirations and/or tidal volumes. Children with respirations fewer than 12 breaths per minute or more than 60 breaths per minute and altered level of consciousness and/or inadequate tidal volume should receive assisted ventilations with a BVM. The blow-by method is not nearly as effective as a face mask or a nasal cannula for delivering oxygen. It does not provide high concentrations of oxygen, but is better than no oxygen. Administering blow-by oxygen, place the oxygen tubing through a small hole in the bottom of an 8-ounce cup. Connect the tubing to an oxygen source set at 6 liters per minute and hold the cup approximately 1 to 2 inches away from the child's nose and mouth. This can also be done by just cupping your hand too. If you don't have a cup, you can just hold onto the tubing and kind of cup your hand and put that close to the child's mouth as well. Some pediatric patients prefer the nasal cannula. Others find it uncomfortable. Applying a nasal cannula, choose the appropriate size pediatric nasal cannula. The prong should not fill the nares entirely. Connect the tubing to an oxygen source and set it at 1 to 6 liters per minute. Here's the nasal cannula as well as blow-by. A non-rebreathing mask delivers up to 90% oxygen if the pediatric patient and allows them to exhale all carbon dioxide without rebreathing it. Apply a non-rebreathing mask. Select the appropriately sized pediatric non-rebreathing mask. The mask should extend from the bridge of the nose to the cleft of the chin. Connect the tubing to an oxygen source and set it 10 to 15 liters per minute. Adjust oxygen flow as needed to match the respiratory rate and depth. And then a bag valve mask. Indicated for pediatric patients who have respirations that are either too slow or too fast, who are unresponsive, or who do not respond in a purposeful way to painful stimuli. Assist using a BVM. Ensure that you have the appropriate equipment for the right size. The mask should extend from the bridge of the nose to the cleft of the chin. Maintain a good seal with the mask on the face. Ventilate at the appropriate rate and volume using a slow, gentle squeeze. Stop squeezing and begin to release the bag as soon as the chest wall begins to rise, indicating that the lungs are filled to capacity. This procedure is similar to the one-person BVM ventilation, one-person BVM versus two-person BVM. We've learned about this in CPR. The procedure for two-person BVM is much more effective because one person maintains the face seal and the other maintains the head position and ventilates. Usually more effective in maintaining a tight seal, and it provides an open airway due to proper body position. And here's pictures of both the non-rebreather and the BVM. We talked about two rescue BVM. Cardiopulmonary arrest. Cardiac arrest in infants and children is most often associated with respiratory failure and arrest. Children are affected differently than adults when it comes to decreasing oxygen concentration. Adults become hypoxic and the heart develops a dysrhythmia that leads to sudden cardiac death. This is often in the form of ventricular fibrillation. AED is the treatment of choice. Children become hypoxia and their hearts slow down, becoming more bradycardic. The heart will beat slower and more weakly until no pulse is felt. The overall survival rate from cardiac arrest in the pre-hospital setting is about 8%. Pre-hospital survival rate from respiratory arrest is over 70%. A child who is breathing very poorly with a slowing heart rate must be ventilated with high concentrations of oxygen early to try and oxygenate the heart before cardiac arrest occurs. Circulatory emergencies and management. Shock. Shock is a condition that develops when the circulatory system is unable to deliver a sufficient amount of blood to the organs of the body. It results in organ failure and eventually cardiopulmonary arrest. Compensated shock is an early stage of shock when the body can still compensate for blood loss. Decompensated shock is a later stage of shock when the blood pressure is falling. In pediatric patients, the most common causes of shock include traumatic injury with blood loss, especially abdominal, dehydration from diarrhea or vomiting, severe infection, neurologic injury such as severe head trauma, severe allergic reaction, anaphylaxis to an allergen such as an insect bite or a food allergy, disease of the heart, a collapsed lung, a tension pneumothorax, blood or fluid around the heart known as cardiac tamponade or pericarditis. Pediatric patients respond differently than adults to fluid loss. They may respond by increasing their heart rate, increasing respirations, and showing signs of pale or blue skin. Signs of shock in children are as follows: tachycardia, poor capillary refill time greater than 2 seconds, and mental status changes. Begin treating shock by assessing the ABCs. Intervening as required. If there is an obvious life threat, external hemorrhage, then the order becomes CAB because bleeding control is the most critical step. If cardiac arrest is suspected, then the order also becomes CAB because chest compressions are essential. Pediatric patients in shock often have increased respirations but do not demonstrate a fall in blood pressure until the shock is severe. In assessing circulation, pay attention to the following. Pulse, assess rate, quality of pulse. Is a weak, thready pulse is a sign of a problem. Anything over 160 beats per minute suggests shock. Skin signs. Assess temperature and moisture of hands and feet. Capillary refill time, a 2-second capillary refill time is normal. Color, assess skin color. Changes, a change in pulse rate, color, skin signs, and capillary refill time are all important clues suggesting shock. Blood pressure is the most difficult vital sign to measure in pediatric patients. Blood pressure may be normal with compensated shock. Low blood pressure is a sign of decompensated shock requiring ALS and rapid transport. Assessment should include taking all of the parents or caregivers to determine the signs and symptoms first appeared and whether any of the following occurred: decreased urine output, absence of tears, sunken fontanelle, or changes in level of consciousness or behavior. Limit your management to simple interventions. Do not waste time performing field procedures. Ensure the airway is open and prepared for artificial ventilation. Control bleeding. Give supplemental oxygen by mask or blow-by. Continue to monitor the airway and breathing. Position the pediatric patient in a position of comfort. Keep the patient warm by blankets or by turning up the heat in the patient compartment. Provide immediate transport and contact ALS backup as needed. We'll go ahead and stop right here.